All right, so here we are with Module G. This is restorative care, and we are going to talk about your role as a nurse aide in restorative care and what restorative care is. We're also going to talk about specifically bowel and bladder training, because you may have never heard of bowel and bladder training, but it's really if we have a patient or a resident who is on a bowel or bladder training program, it is so important that we are consistent and follow the care plan precisely. And so we'll talk about that in a minute. But first off, what is restorative care? Well, restorative care is any kind of care provided after rehabilitation when the resident's highest possible functioning has been restored following either an illness or injury. So someone's been ill or injured, they went through rehabilitation, and now we're in restorative care. We're maintaining that function that they regained back. So the goal is to maintain the function that has been restored through rehabilitation and to continue to increase independence. All right. So basic restorative care is important for several reasons, because its emphasis is on maintaining or improving existing abilities. For some patients, we might not be able to get back to 100% in all cases, but if we know that we have met the maximum in ability, we want to at least maintain that, okay? Now, if we think there's room for improvement still, even better, right? So we're maintaining or improving existing abilities after rehabilitation. It's important to prevent any further complications, and it's aimed at moving individuals towards independence as much as possible, and to encourage residents to do as much as they can, as long as they can, for as often as they can. It's a team effort to assist residents to develop a productive lifestyle, and it's important to assist individuals to accept or adapt to any limitations that rehabilitation was not able to overcome. So before we get any further, does anybody have any personal experience, I'm not necessarily with yourself, but with family members or friends, where you have been through rehabilitation and or restorative care? Does anybody have any examples or experience with that? Okay, well, then let's talk about it some more. You're going to get lots of experience with people who have been through rehabilitation once you get into the clinical setting. So your role, the nurse aide, is often the first healthcare provider to recognize signs that someone is feeling, like a loss of independence. You might see that they start to develop a negative self-image. They might get angry and directed towards others. They might feel helpless or hopeless, useless. You may see them starting to increase their dependence on you, right? Or become depressed. If we notice these things, we need to make sure that we're reporting it right away. And I know I gave that example earlier on. If a resident earlier on in class, that if you start to do things for your resident, even though they can do it themselves, they're actually going to decline, okay? So this goes against restorative care, right? We're trying to maintain or improve their abilities. So if we notice our resident is trying to be more dependent on us, we need to be encouraging and also be notifying the nurse. We want to encourage our resident and the family when there is some sort of functional loss or loss of independence, because it will cause these feelings, and that's normal and natural. But we want to be sensitive to these needs, knowing that some people may even be embarrassed by the loss in independence, and we want to again, encourage and reassure our patients. We want to be positive and supportive, make sure to emphasize the abilities that they do have. When we're doing activities, especially if it's something they're having to learn a new way to do a certain activity, we want to make sure we explain it and also tell them how we are going to help them and assist them and what we expect them to do as far as maintaining their independence. Treating with respect and dignity is always, a priority. And then again, assist them to do as much as they can and be realistic. We don't want to give false hope, right? We can be positive and encouraging without giving false hope. So our role again is to review the skills that will be needed to assist with any restorative activities. And we want to focus on small tasks and accomplishments. Sometimes trying to do too much at one time can be overwhelming. So if we break our activity into smaller tasks, that can actually be really helpful for our residents. And we need to recognize in ourselves, but also for our residents' sake, that setbacks are going to occur and setbacks are normal. And knowing that that doesn't mean it's not ever going to be accomplished. So we want to encourage our residents to continue with the plan of care, even when we have these setbacks. We always want to give resident as much control as possible and allow for choice when appropriate and when possible as well. We want to be patient when we're preparing our residents and ourselves for the activity, provide rest periods as needed, encourage, if they do now have any kind of adaptive or assistive device, we really want to encourage the use of it. Sometimes when someone has a new adaptive or assistive device, they can be resistant to it, and we wanted to encourage them to use these. And if the resident gives permission, we want to encourage family to be involved as much as possible while maintaining that independence. Go ahead, Cheyenne.
A simple example is like weight spoons while eating. They're thicker,
Yeah.
bulkier.
Yeah, and that's a great example. And I think, in fact, I have maybe some pictures of some different adaptive and assistive devices that we're going to see in a second here. So yeah, that's a great example. And actually, before we get to those, though, we're going to talk a little bit about prosthetic and orthotic devices and what the difference in those are. So a prosthetic device is, we're talking about prosthetics. That's a replacement for the loss of a body part. So a prosthetic is going to be specifically fitted to that one person. This could be like a hip prosthesis, like an artificial body part, like a leg or a hand. So our role as the nurse aide is, first of all, to know that these devices are really expensive. So we've got to really treat them with respect and be careful with them. Before we assist our residents to putting any prosthetics on, we really need either the therapist or the nurse to make sure that we understand how to properly do it. There's going to be specific instructions for the areas where the prosthetic is being attached, and that's, might be like padding, or we are always keeping the skin that is in contact with the prosthetic clean and watching for pressure, right? Because this is where pressure points can happen, abrasions, breakdown of any kind. And make sure that there's not any particular rubbing in an area. Again, that's going to cause injury. So just like we were kind of talking about already, we want to be empathetic to patients as they adjust to having a prosthetic, because this will take a toll. It can take a psychological toll on our residents. So we want to be supportive but encouraging to use them. Now, an orthotic device, this is something that helps to support and align a limb to help us with our function of that limb. So this might be like a splint or a brace or some kind of shoe insert. Our role with this is to understand, that these devices are typically specific to a resident as well. So it's not like a shared piece of equipment. We want to, again, make sure we're trained on how to properly put them on. Some will require some padding, and we're always being conscious and aware of rubbing, skin breakdown, pressure points, etc. Supportive devices I don't like that they use this same image for this, so ignore that lovely gentleman for a minute. Supportive devices, this is special equipment that helps a disabled or ill resident with movement. So that could be like canes, walkers, crutches, or wheelchairs, for example. Whereas assistive or adaptive devices, and this is getting into what Cheyenne was talking about, this is special equipment that helps a disabled or ill resident perform their activities of daily living. So assistive or adaptive devices help us to do our activities of daily living, which of course is going to promote independence. And successful use of these devices is really going to depend a lot on our residents' attitude, acceptance, and motivation, but also just our support in our family, and their family support. So assistive devices that can be used for positioning might include pillows. So those are actually considered assistive or adaptive devices. But there are other kind of pillows that are just your kind of standard that you think of. You might have cylindrical pillows, wedge pillows, all of these different things. That abduction pillow, that's used for patients after they've had hip surgery. Um, web, 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 wedge pillows or these cylinder pillows can be used to like float your heels or support your neck. There's these bed cradles. These can keep the bed covers off the legs and feet. Sometimes, depending on what condition a resident has, even the lightest little bit of pressure on the lower extremities can be really painful. And so this is to keep the pressure, even that tiny bit of pressure from the blankets, off of the lower extremities. We've also got assistive eating devices. Let's see what else. We've got angled utensils. So when somebody has limited arm or wrist movement, they can use the angled utensil so they can still feed themselves. Sipper cups. So if they're a little shaky or they just have, unsteady grip, they can use these cups and still be able to drink on their own and not worry about spilling all over themselves. The large grip utensils, plates with like the lips around the edge, like you see there. A lot of people sometimes they just have trouble scooping. So to maintain their independence in feeding themselves, they might just need that kind of lip on the edge of the plate like that to be able to scoop their food on. There's also, these are other examples, the straw cup, the large grip handle with a flexible handle so you can bend it to work best for that resident. There's shirt and jacket pulls to help you be able to button your own buttons. And zip your own zippers. I mean, I didn't even know some of these things existed until I started teaching this class. I knew about a lot of them, but some of them I hadn't seen. There's sock and stocking aids, long-handled shoe horns to get your shoes on. We've got electric toothbrushes, denture care kits, fingernail brushes. Those are the fingernail brushes. There's these extra long handled sponges so that people who can't really reach well can still bathe themselves adequately. You maybe have heard of or seen this device. This is a device used by residents with diabetes so that they can actually examine their heels for any kind of sore or abrasion and wash their feet. If you don't know much about diabetics, they tend to have neuropathy in their low extremities and poor wound healing. So it's not uncommon for diabetics to get like the tiniest little cut on their foot. But to them, it's going to turn into a terrible wound that could result in amputations if they're not careful. So it's really important for our diabetic patients that we're paying attention to their feet and their lower extremities. And this device will aid them to do that and maintain their independence. We've also got reaching tools that can help. When my mom got her knee replaced, I bought her one of these so she could still, grab and be independent as much as possible while she was healing a bit. So when our residents use these devices and these adaptive tools, it's wonderful, right? But we have to report and record on these things as well. So here's the things that we need to record as nurse aides. We need to say, what activity was the resident attempting? What devices did they use? Were they successful? Did we notice any increase or decrease in ability? What about their attitude? How did they feel about it? How did they respond? And did we notice any changes in their health? And what we mean by that, like, did it take a lot of effort? Was Betty like huffing and puffing when she was done? Did she turn pale and diaphoretic? Did it exhaust her for the rest of the day and she slept 5 hours? Or did she do great, right? So we need to make sure that we're documenting these things. So some things to always remember with restorative care. Sometimes, and we've talked about this a lot, sometimes it may seem like it's easier and quicker to do something for a resident, but we really need to maintain that independence as long as possible. And now we're going to talk specifically about that bowel and bladder training that I was talking about. So bowel and bladder training are the measures taken to restore function of urination and defecation by a resident with the ultimate goal of continence. So what we mean. So continence is our ability to control our bowel and bladder. If we are incontinent, for a variety of reasons it can happen, if we are incontinent, it means we do not have control of our bowel and bladder. In some situations, regaining continence is possible. And I don't know about you, but if there was if I was incontinent and there was any chance that I could gain that continence back, I better be sure I would want to do it, right? And this is what I was saying earlier. It's usually 8 to 10 weeks of a bowel and bladder training program, which will feel like a long time, but it's worth it, obviously. But it really takes a lot of dedication and consistency and accuracy on our part as caregivers. So it's really important. So a couple of key vocabulary words here in case you're not familiar. So urination, of course, is emptying our bladder. Defecation is entering the rectum of feces. Continence, ability to control urination or defecation. And incontinence is our inability to control those. Incontinence can be embarrassing for residents. It's going to limit their lifestyle, right? If you didn't know when you are going to defecate into your underwear, it might stop you from going to play bingo with your friends. Odors can be unpleasant, and sometimes family members might tend to not come around as often if it's always an unpleasant smell or situation. Infections can happen, urinary tract infections, skin breakdown, more pressure ulcers. Residents may find it difficult to discuss or ask for help in these situations as well. So what we need to remember is we're a valued member of the team, and we are, along with the resident and their family members, often involved in bowel and bladder training or retraining. We want to always support the explanation by the doctor or the nurse, and we want to do so with privacy and while maintaining dignity and respect. Their roommates, they're not going to want their roommate to hear the detailed plans of their bowel and bladder training and their incontinence, so keep that in mind. We have to keep accurate records of bowel and bladder patterns and amounts. We have to answer call lights promptly. We're always answering call lights as prompt as possible, but when you know someone's on a bowel and bladder training program, you got to get there. And we always want to be patient. If someone's on a bowel and bladder training regimen and they're sitting on the toilet to try and go, we have to be patient with them and allow them that time. We want to be positive, assist to the bathroom if requested, provide privacy and encouragement, and offer fluids as scheduled, because that's going to be an important factor in the bowel and bladder retraining. Also encouraging and helping them to make sure they're getting high fiber foods, because fiber has a big role in our elimination patterns and regularity. Also does regular exercise is important. Good peri-care, keeping the bed and linens clean. So when someone is getting bowel and bladder training, their attempts to void are scheduled. So the resident is encouraged to avoid when they wake up, 1 hour before meals, every 2 hours between meals, before going to bed, and then just as needed throughout the night. There are some things that we can do to help encourage someone to be able to go to void. Running water in the sink, putting the resident's hand in warm water, offering fluids, having the resident lean forward slightly at the way, like if they're sitting on the toilet to go pee, if you have them lean forward slightly, that actually puts a little bit of pressure on the bladder and can really help a lot to help someone void. Another thing you can do, and you always want the resident to check the water temperature before you do this, but it can be really helpful, is pouring just a little bit of warm water over the peri area. The peri area is our private area that it's called the perineal area. So you'll just become familiar with that term. And we do peri-care as one of our skills on the mannequins. But pouring warm water over the perineum can really help. When we're doing the bowel training, which you'll see versus, that was more geared towards the voiding urination. When we're talking about bowel training specifically, this is going to often involve enemas, laxatives, and suppositories and stool softeners. Enemas, if you're not familiar with what that is, that's the introduction of fluid into the colon, and that's going to help to both eliminate stool and also stimulate like a bowel movement. So enemas will be ordered by the doctor. And there are different types of enemas. You might just have a tap water, a saline, or a soap suds. Sometimes there's commercially prepared enemas. Nurse aides, just as a nurse aide 1 going into your first job, you are not trained to do enemas, so you should not be doing those. But if your facility trains you to administer them, then it may become part of your job description. So important things to remember is that bowel and bladder retraining can be accomplished. The staff has to be consistent and follow the plan, and you have to record and report accurately and in a timely manner for this to be successful. And like I mentioned earlier, it can take 8 to 10 weeks for bowel and bladder retraining, but obviously definitely worth it. Does anybody have any questions about any of that?